Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
When studying for national boards, it's a little different than some of the other approaches that you've used in your previous classes. And really there's a sort of a strategy that I'd like to introduce first before we start our review of the area. You all received, or should have received, this candidate's guide for the National Board of Dental Examiners guide, and in there with an introduction and a way of reviewing for the national. The purpose of this tape is to provide you with an introduction and a way of reviewing for the national boards in the area of gross anatomy. When studying for national boards, it's a little different than some of the other approaches that you've used in your previous classes. And really there's a sort of a strategy that I'd like to introduce first before we start our review of the area. You all received, or should have received, this candidate's guide for the National Board of Dental Examiners guide, and in there you'll find a list of the areas that you'll be tested on in this part 1. In anatomy, for example, you'll find such an outline, and in studying for a national board, it's a good idea to look at the examination, the way it's formatted and how it's put it together. What I mean by that is that the distribution of gross anatomy questions is, if you look at it, is now done by region. 58% of that is coming from the head and neck area, and the axilla and shoulders are 7%, thorax 23%, and the abdominal cavity, pelvis, and perineum altogether make up only 12%. And so what I would suggest as you begin to study and prepare for this examination is to emphasize those areas according to the percent in which they're likely to appear. Incidentally, so to help you today, I've provided you with an outline series that you have been given by your classmate, and you can work your way through that. We'll be using some of that actively during this session, and other portions of it are really designed for you to take home and use as a quick review system. What are the strategies then and approaches? Well, first you need to realize that the question structure is going to be multiple choice. That means it's going to be a recognition type level of knowledge. You aren't going to have to be pulling it back from nowhere. This requires, as I say, recognition only. And most of the questions that you'll be getting are strictly multiple choice. There are occasionally multiples. In other words, ones in which maybe A, C, and D, C and B, or none of the above are correct. In those cases, another strategy is to watch for something that you know is absolutely wrong. And once you see that appear, you know you can throw that out of your answering scheme. In reviewing, you want to look for pre-digested, I call it, bits of information for rapid review. What are some of those sources? Well, outlines of the essential vocabulary that you'll find in your laboratory guides, and texts such as Woodburn and Burkle. I would suggest you look over the first chapter rather thoroughly, and then use the rest of the book as a source for simple diagrams and a way of reviewing patterns, especially of strategic nerve areas and arterial patterns. But let's start today by looking at some slides. And what I'd like to start out with is the osteology of the skull, and we'll start through with that and then move forward from there. I want to remind you that the skull can be divided up into basically two parts. A neural cranium, which is of course this area up in here in the facial region. Occasionally in referencing in the questions you'll get that sort of an arrangement. See if I can focus this a little bit here. Here we go. The orbit is not going to be covered in any great detail on the test, most likely at least, but there are some foramina and entrances that I'd like to just remind you of. Of course, the first is the optic canal here, the superior orbital fissure, the inferior orbital fissure, and then this leads to an infraorbital groove and an infraorbital foramen at this point. Do remember the location of the lacrimal sac fossa as opposed to the lacrimal gland, which sits up here in the lateral area in a lacrimal fossa up here. When we consider the lateral view of the skull, the first thing you want to remember is that you have got this large area in here which we refer to as the temporal fossa. That fossa, as you sweep down the side of the skull, changes rapidly at this point. It's called the infratemporal crest, and at that point you flow into this deep portion of the face called the infratemporal fossa. Much of dentistry and head and neck anatomy is going to be centered in this area, and a lot of your osteology questions are going to be located here. For example, at the infratemporal crest we have the roof, then the pterygomaxillary fissure, which separates this lateral pterygoid plate from the area of the maxilla here, the infratemporal surface of the maxilla. And as you continue downward, we can see that there's an extension of the medial pterygoid plate here, which is a good bony landmark in the mouth, the hamulus of the medial pterygoid plate. You can actually palpate that beneath the mucosa in individuals. As we swing posteriorly, we're now into the area of the temporal mandibular joint. Some critical points there. This is the articular eminence, this bar of bone here, and the articular tubercle is a small tubercle here at the base of the zygomatic arch. The area of the fossa itself is made up of two parts, the articular portion here and the non-articular portion here. This little groove that's in here is the petrotympanic fissure and separates those two parts. Of course, you remember the styloid process and many of the other details of this area. This area, again, is the infratemporal fossa. Let's look down in here and some other major landmarks in the oral region. The orifice for the greater palatine nerve is here and lesser palatine nerve behind it. The area for the sphenopalatine artery and nasopalatine nerve is pretty much hidden in here behind the central incisors. Notice the terminology, sphenopalatine artery and then the nasopalatine nerve. Next slide. The skull base is really going to show you many of the things we just talked about. We've got the foramen for the greater palatine nerve here, and you have the nasopalatine entrance here, lesser palatine foramina here, and the hamulus. Do recall that the mandibular division of the trigeminal system comes through ovale, foramen ovale at this point, and that you are going to find that the other divisions, the ophthalmic and the maxillary, have entered the facial region anteriorly and don't open here at the base of the skull. The other major point of interest in here, of course, is the area of the jugular foramen, which is this specific area here, and the external opening for the internal carotid, which is located there. Most of the cranial nerves, which are going to supply the posterior portion of the deep face, are going to be coming out of the jugular foramen at this point. Even some of those, which, for example, here in foramen magnum, if you go forward, you'll find the opening for the 12th cranial nerve. it will pass through here, but then reappear in the area of the jugular foramen to join the base of the carotid sheath. Let's go to the next slide. Internally, I just want to remind you that the base of the cranial cavity can be divided up into an anterior fossa, a middle cranial fossa, and a posterior cranial fossa. This lesser wing of the sphenoid makes the demarcation between the anterior and middle, and this petrous ridge of the temporal bone makes the division between the middle and posterior. Then another critical point in here, of course, is the sella turcica, and we'll be talking about the cavernous sinus concerns here. In terms of the nerve foramina, they're going to pass through it. You have in your handout a drawing of this area, and you can review those with you. I'll just simply remind you that the trigeminal system, the major sensory system to the face, the ophthalmic, is going to be passing through the superior orbital fissure, the maxillary nerve through foramen rotundum, and the mandibular through foramen ovale. There are going to be a series of nerves that will pass through the cavernous sinus. We'll talk about those later. The jugular foramen, again, is here and is going to be transmitting a series of cranial nerves. And as you can see here, foramen magnum and the 12th cranial nerve passing out at this point. With regard to the mandible, some of the bony landmarks that you want to remember, of course, the coronoid process and the condyle, the sigmoid notch or mandibular notch. Here, the mandibular foramen. And then you will notice, of course, the lingula and a line which is going to pass across this portion of the mandible called the body, and you can see it running tangentially across here, is the Mylohyoid line. Recall that this divides the oral cavity into the perioral area above it and the submandibular area beneath it. You can see the groove for the mylohyoid nerve passing here just outside the mandibular foramen. This prominent notch at this point is called the premastoteric notch. You can see it again here. It's a notch that lies just anterior to the masseter, which attaches here laterally. Important landmarks of the mandible from above. The most important is that the fact that the mandibular arch, dental arch, fits inside the base of the mandible. And you notice here that there is a small triangle of bone behind the last molar tooth. This is called the retromolar trigone, and this apex is the attachment point for the pterygomandibular raphe, pterygomandibular raphe. You'll notice here, running from the tip of the coronoid down, is an oblique line, and it traverses the external portion of the body of the mandible. If we move from bony landmarks of the head, we'll of course pass into the muscles of mastication. This is an area that frankly, you already have talked about in so many of your courses that I just simply want to remind you that temporalis, of course, filling the temporal fossa, is one of the more superficial muscles. The masseter here, you can see its superficial head, and there is usually a deep head portrayed posteriorly. You can notice the way these interdigitate with a portion of the facial muscles, in this case the buccinator passing deeply and deep to this superficial portion of the masseter. Incidentally, I have incorporated a chart that's in that handout for you, and you will find a review of the actions, attachments, innervations, and so forth for each of these muscles of mastication. The two deeper muscles are seen here. Let me see if I can focus this just a little bit for us. There we go. Here you can see the superior and inferior head of this lateral pterygoid. You recall that its origin is going to be from the lateral pterygoid plate and the roof of the infratemporal fossa, sweeping back to the disc of the temporomandibular joint and to the neck of the condyle. This is the only anteriorly oriented muscle of mastication. Here, and lying deep for the most part, is the medial pterygoid muscle. It's taking its origin from the medial side of the lateral pterygoid plate and passing down to the area of this angle of the mandible. You'll notice that these deeper muscles of mastication are intimately associated with arterial and nervous elements of the infratemporal fossa. This, for example, is the maxillary artery, which is passing, in this case, superficial to the lateral pterygoid muscle and giving off its branches. We'll talk about that a little bit further. You'll notice here, in relationship to the lateral pterygoid muscle, a critical arrangement with the mandibular division of the trigeminal system. Some nerves, for example, here, the deep temporal nerve, posterior deep temporal, is passing above it, and the nerve to masseter above the superior head. Coming through between the superior head and inferior head, you're going to have another branch, which will come down here, most notably the buccal nerve. And then finally, the two major nerves of concern for dentistry, the lingual nerve and the inferior alveolar nerve, pass out beneath this muscle. The temporomandibular joint we'll be talking about a bit later on, but again, this is an area that I think you probably had quite a bit of review in your other classes. I might mention and just point out that there's a nerve which sweeps up through here. It's another branch of the mandibular division called the auriculotemporal nerve. It's the major nerve supply to the temporomandibular joint. There we go. Okay, and the next. In terms of the muscles of facial expression, and I should have mentioned with the mandibular, or excuse me, with the muscles of mastication, it is the mandibular division which is going to supply the motor supply to them. As opposed to the muscles that we're looking at now, the muscles of facial expression, these are all innervated by the seventh cranial nerve. Now, the muscles of facial expression find themselves condensed around the oral area, the nose, and the eye. For the most part, in terms of this examination, it's only these perioral ones that are going to be of import to you. And let's remind you that in this area, the muscles tend to insert into an area called the modilus. It's a sort of a hub, a center point on a wheel, and it's located here. Some of the muscles are coming in this case, from the side, the zygomaticus major, for example, and the depressor anguli oris. Orbicularis oris is the muscle which is going to form a sort of sphincteric arrangement between the upper and lower lips, and it's met posteriorly by the deepest muscle group of the face, the buccinator. It too will come in from the deep area and come forward to attach to the modilus. Other muscles of this area are not going to attach in this point here, but rather between that point and the midline. In the maxilla or in the upper arch, for example, we have the zygomaticus minor coming in, the levator labii superioris, and then finally the levator labii superioris aliquinesi. That's the muscle that sweeps down here, attaching both to the nose and the upper lip. Inferiorly, the depressor anguli oris, you'll notice, is coming in the midline rather than out at the angle. Notice the difference between depressor anguli oris, which is going to be a superficial muscle, and levator anguli oris, which is a deep muscle. Both come into the modilus, but they come from different positions. Again, the platysma muscle down in here is one of the facial muscles that you'll be concerned with. All of these are innervated by the seventh cranial nerve, even including this deeper muscle, the buccinator. The buccal nerve, which sweeps out in this area, is supplying sensory innervation to this area, not motor. A critical point to remember. If we work into the palate area, this area is anterior, this is posterior, superior, and inferior, of course. Here you can see the tongue dorsum coming down. And this is a midline section through the palate. The muscles that make up the palate are all innervated by the 10th or vagus nerve, with the exception of one, which is hidden right here. And we'll just start off with that one. It's out, the muscular portion of it lies lateral to the palate. It then turns around the hamulus and comes in and reinforces the soft palate and the aponeurosis of that palate. It's called the tensor villi palatini muscle, and it's innervated by the mandibular division of the trigeminal system. The other muscles of the area, the largest, the levator villi palatini muscle, as you can see, appears to come out of the torus tubarius, the pharyngeal opening of the auditory tube, sweeps down and provides most of the muscular bulk for the soft palate. The uvularis muscle is just a simple thin midline muscle which passes down into the uvula and acts to pull the uvula back up during elevation of the palate to help build up the bulk in this area for closure. Inferiorly and anterior in this position, we can see palatal glossus muscle. This is an interesting muscle. It's palatal glossus. Even though it attaches to the tongue, its innervation is associated with the palate and therefore with the 10th cranial nerve. Palatal pharyngeus, which sweeps down posteriorly here, the same thing applies. Palatal meaning again the palate innervation of 10. Other muscles that are associated in this area we can see from this torus tubarius in the nasopharynx, a thin muscle coming down here, salpingopharyngeus. We can see the superior pharyngeal constrictor muscle in this area, and we can see that there are other portions of the pharyngeal constrictors, in this case the middle pharyngeal constrictor here. Let's take a look at those pharyngeal constrictors and what makes up this tube. This is simply to remind you, and here we have the ear opening, the styloid process. So this is anterior, this is posterior, and we're looking at a lateral view of the muscles that make up the pharynx. Here we can see the cartilages that make up the area of the larynx. We can see the hyoid bone. You have the styloid process, as I mentioned, and we have portions of this infratemporal surface of the, or infratemporal structures, I should say, of the skull. The superior pharyngeal constrictor, which has the largest anterior attachment, attaches to the area of the pterygoid plate, the medial pterygoid plate. It then will swing down to the area of the hamulus, at which point it jumps across and joins the buccinator muscle, and that junction between the superior pharyngeal constrictor and the buccinator is this pterygomandibular raphe, one of the landmarks for your injection during a mandibular division block. The attachments anteriorly of the superior pharyngeal constrictor then continue inferiorly to attach to the area of the mandible down in here, medial to the retromolar trigone. The middle pharyngeal constrictor is attached anteriorly to the hyoid bone and to the stylohyoid ligament. The attachment runs from here on the stylohyoid ligament to the lesser horn of the hyoid along the greater horn, and then swings back. Notice that the middle pharyngeal constrictor overlaps the superior pharyngeal constrictor, and in the same token, the middle or the inferior constrictor overlaps the middle. The inferior constrictor is a very large constrictor. It attaches to the thyroid cartilage along its oblique line, to the cricoid cartilage at this point, and then it leads directly down into the area of the esophagus. So that just roughly goes over the muscles of the pharynx for you. The tongue is the last area of musculature that I want to talk about in the oral area, and the tongue breaks itself up into two types of muscle, the extrinsic and the intrinsic muscles. Illustrated here are the extrinsic muscles. These are muscles that start outside the tongue, attach outside. For example, in this case, the hyoid bone is located here, and this is the hyoglossus, which we see coming up in that fashion. The styloid acts as a point of origin for the styloglossus muscle, which comes into the tongue from the styloid process. And anteriorly, in the area of the mandible, we have something called the genial tubercles. The superior genial tubercle gives rise to the muscles which are going to come in from the glossus. The inferior tubercle will lead to the hyoid and is a genial hyoid muscle. It's not a part of the extrinsic muscle of the tongue. The others that we've talked about are the genioglossus, hyoglossus, and styloglossus. Notice that I left the palatal-glossus out, and I mentioned to you that belongs with the soft palate. Intrinsic muscles of the tongue are muscles which take origin and insert within the tongue, and they're mainly used to shape and change the shape of this portion of the blade of the tongue. They can either pull from side to side, in which case narrowing the tongue, or they can move from anterior to posterior and shorten the tongue. And they can also are oriented in a vertical fashion so that they can flatten the tongue as well. Both the intrinsic muscles and the extrinsic muscles of the tongue are innervated by the hypoglossal or 12th cranial nerve. You need to remember that. And we'll talk a little bit about the sensory area of the tongue. The tongue is a really complex neurologic area, and it really underlies a rather complex embryology. Now what I'd like to do is to switch areas, and we'll start working in the area of the thorax and abdominal region. As you can probably tell from my introduction and from the slides that you've seen so far, the intent in this review session is obviously not to cover all the anatomy of a given area. It is to point out to you areas that I know from my experience with it are ones that are likely to appear on the boards. And more to the point is just to get you listening to anatomical terms again so that they will help you in terms of recognizing a correct answer on that examination. Now, let's go to the overheads for this area on the thorax. Obviously, the first thing we want to consider is the cardiopulmonary area. In the case of the heart, I simply want to remind you of some things that are pretty elementary, but actually do form the basis for a lot of the questions in this area. Obviously, you have got the area in black, what we would call then the right heart, and the area in white, the left heart, the unoxygenated blood flowing into the area, and the oxygenated blood coming back into the left heart and passing out. There are a series of valves here, which we might just start out and discuss. Here you can see the right AV valve or atrioventricular valve. See if I can find a better pointer here for us. Let's try this one. On the atrioventricular valve, this is also a tricuspid valve, as opposed to the left atrioventricular valve, which is shown here, which is a bicuspid or mitral valve is another term for it. The other valving set that you have in here, this of course is separating the atria from the ventricular area. The other ones are called the semilunar valves, and we can see one in this case in the outflow on the left side, and we would call this one the left semilunar valve. And this one then is the aortic valve. As opposed to over here, we can see the right semilunar valve. And I'm just going to put in here SL. And this one is called the pulmonary valve. It's just above this aortic valve, the aortic semilunar valve, that the outflow to the heart, now this of course is a section through the heart, but coming out just above that is where your coronary circulation is going to occur. The right and left coronary arteries are going to arise just above the semilunar valves. What are some other things we've got going here? Well, obviously you've got the inferior vena cava. And incidentally, this is in your notebook that or handout that I've given you, so you can take some of these notes and make them as complete or handle them as you wish. This is our superior vena cava, both coming into here. The return to the heart itself, from the heart itself, is sweeping in from behind and is coming in from the coronary sinus. That's the venous return for most of the heart, and it sweeps in and comes into this right atrium. Other major vessels that you can see here then, we mentioned already that we have the pulmonary valve right here, and it is leading then to the pulmonary trunk. Which leads then in turn to the pulmonary arteries. And you'll notice that that is the one case where you've got an artery that's carrying unoxygenated blood. Here, of course, we have got the pulmonary veins returning the blood. To the left heart. Also leaving the left heart, this portion of the aorta is referred to then as the ascending aorta. And that will eventually lead to the descending aorta, which doesn't show up on here. Coming off of the arch of the aorta, we can certainly see the major vessels which are leaving this area. You recall that on the right side, we are going to have the brachiocephalic. Artery, and that is going to lead to two vessels which actually come off separately on the left side. In this case, we have the left common carotid and the left subclavian. This brachiocephalic artery on the right side is going to then divide up into these two elements on the right side. But that's just, as I say, one of the major details there. Now, if we just shift over to this other diagram, which you have here, you can see some of those vessels as they are coming from the heart. This figure I'm sure you recognize from Woodburn's text. But the thing I want to point out to you is the veins are superficial to these arteries. We can see the arteries that we just noted. The veins, I'll just point out to you the arrangement here. The internal jugular is going to be joined by the subclavian on the left side to create a relatively long subclavian on the left. On the right side, we have the two major vessels again coming together, the jugular and the subclavian, and then a short right brachiocephalic vein. Notice that we have a right and left brachiocephalic veins while we have only a brachiocephalic artery, point we just talked about. These two brachiocephalics combine to form the superior vena cava. While we're talking about the major vessels of the area of the heart, the other thing I want to mention here is lymphatics. And there's not an awful lot that you need to review in that area, but I would like to point out that they are going to be coming in on the right side right here and the left side right there. Now, I don't know if that'll show up. Let me just mark it in a different color here. Let's try just putting in some red. These are the 2 points that they're going to enter the venous system. Now, the lymphatics, the thing that I want you to keep in mind is that you have a jugular trunk on the right side, which is coming down. I'll label it in a second. A subclavian, which is coming in, and one coming from the anterior chest area, which is going to be coming up in here, bronchomediastinal. Now, we have exactly the same pattern over here on the left side, except that we have an additional one which is going to be coming from way down inside and arching up and coming in at this point. And so the critical points, and I'll label these right now, that we need to remember are this. Here you see that you have the right lymphatic duct, and it's being formed by these 3 elements. The one that's most important here from the head is the jugular trunk. Jugular lymphatic trunk, the subclavian from the arms, subclavian trunk, and the bronchomediastinal from the anterior chest wall. Same thing over here on the left side, but as you can see, we have this one we'll just put in here as a jugular trunk, the subclavian trunk, and bronchomediastinal. And the big difference is right here, and that's the thoracic duct. Let me just slide this down a little bit. I'm sorry, I didn't catch it there. There we go. Now, the big difference that you've got here is then that the head and the upper extremities and anterior chest wall are drained into both the right and left sides. The difference is that the thoracic duct then picks up all the lymphatics from the abdominal cavity, the thoracic cavity, and the lower extremities and brings it back in, so that the greater lymph return is going to be on the left side. It's just a, as I say, a point that is frequently brought out. Okay, let's move next to the pulmonary system and just some quick points of review there. Here, the first thing I want you to notice is this area is the trachea, of course. You'll notice that as the trachea comes down and divides into the principal bronchi, that the right side is much larger in diameter and shorter. The left principal bronchus is narrower and longer. That really sets the tone for this area. There are a couple of things. Aspirated foreign bodies, for example, will end up over here on the right side more frequently than they will on the left. It also is going to affect the way in which the major vessels are going to relate to the root of the lung. You can see here the left pulmonary artery, for example, is riding above this narrow left primary bronchus, or principal bronchus, whereas the right is coming in front of that bronchus. And then finally, when you go to put the aortic arch in here, it's going to loop up and pass over the top on the right, or excuse me, on the left-hand side before it gives off its major vessels. But that sequence again is in your handout, and it's one that you want to look at in terms of just the relationships of these major vessels at the tracheal bifurcation area. Some terminology again, just to remind you, it's the right lung that has got a superior, middle, and inferior lobes. The left side has got a superior and inferior only. There is no middle lobe in the left area. And then just some terminology in terms of the pleura. If you recall, this is just a diagram here of the trachea coming down and breaking up, that the pleura, which is covering the organ, in specific the lung in this area, is the visceral pleura. The parietal pleura is pleura which is surrounding the body wall. The space between these two pleura, the visceral pleura and the parietal pleura, is the pleural cavity. And you can refer to different surfaces of the pleura by the area of the thorax by which they're closely related. For example, that which is close to the mediastinum, this middle portion, versus that which is close to the ribs, the costal portion of parietal mediastinum, or the diaphragmatic portion of the mediastinum. I think that's about all I want to mention right now in the area of the thorax. Next thing I'd like to do is to move down into the abdominal area, and what I want to look at is just to remind you of a couple vascular principles in this area. We're all familiar with obviously the gastrointestinal system, which is diagrammed here. Its major components you can certainly identify quickly. Liver, for example, stomach, duodenum, the ascending colon, the transverse colon. You'll notice the colon comes up here and moves across transversely. And then continues down with the descending colon. Continuing on down then, of course, to sigmoid colon and rectum. I want you to notice something here. Oh, there's one other part of the gastrointestinal system. First, there's this long tube that we've just been through. We notice that there are a couple of glands, the liver, which we mentioned here, and one we have not covered yet, and that you can see it's tucked in under here, the pancreas. But there is also another organ that develops in the area of the abdominal cavity and is within the visceral cavity itself and covered by peritoneum, the spleen. It's the only part of the gastrointestinal system which does not, or the only part, I should say, of the visceral organs which does not arise as an outpouching of this gastrointestinal tract. These organs, as you know, are within the peritoneal cavity. Some of them are secondarily retroperitoneal, and I'll just mark those that are secondarily retroperitoneal. Those that then get fused to the body wall are the ascending colon, the descending colon. This rectum, as it passes through, is really going from a peritonealized state to a non-peritonealized state. But those are the two major structures, and then a part of the duodenum is also secondarily retroperitoneal. So we have these three that I've marked. In the posterior body wall proper, you have some other organs, obviously, that are associated with the abdominal area, plus the fact that, of course, you've got the diaphragm, the respiratory diaphragm, separating the thorax from the abdominal area. Do recall that you have some openings that are going to pass through that diaphragm. In this case, the opening for the inferior vena cava. In this one would be for the esophagus. And finally, we can see the aorta passing through at this point. The posterior body wall organs that we can demonstrate are the suprarenal gland, and the kidney. Now, one thing I want to point out then is that when you talk about the blood supply, the blood to both the gastrointestinal system and the posterior abdominal wall are going to come, of course, from the abdominal aorta. But then we get into two different types of drainages. Those which are draining the gastrointestinal system are going to go back through a system known as the portal system. The portal system then stands between the gastrointestinal system and the return to the rest of the body, which occurs through the inferior vena cava. Inferior vena cava is located at the ends of these two pointers. The posterior body wall organs, such as the kidney, the testis and ovary, the suprarenal gland, are all going to drain through the inferior vena cava directly and back into the system. Now this actually is connected deep to the liver in this diagram, so this is just a simple tube that runs posterior to the liver. But the portal system is a different arrangement. The vessels which are making it up are the following: the superior mesenteric artery, and the splenic artery, excuse me, here I am, I've just done it, I'm in the venous system. The superior mesenteric vein and the splenic vein are going to combine to form then the portal vein. Now this portal vein is then going to pass to the liver, and then the blood will be passed through the liver itself and be recollected, if you want to, after passing through that, through the hepatic veins. Which will then in turn drain into the inferior vena cava. Now the important part of that is that any drugs, for example, that are administered to the gastrointestinal tract have to pass through the liver before they get into the rest of the body. The same thing holds that posterior abdominal wall structures, let's say the suprarenal gland, any hormones produced there will pass back directly into the inferior vena cava and not have to go through the liver. Another thing that happens, because this liver lies right here is basically a gateway between the gastrointestinal system and the inferior vena cava. If there's any disease of the liver that occurs, the liver blocks that blood supply back from the gastrointestinal system. There are, however, two areas in which at least two, in which the venous system from the rest of that bypasses, if you want to, the portal system, can get around the liver if necessary. One of them is here near the esophagus. In the case of liver disease, esophageal varices, a swelling of the veins leaving in the area of the esophagus, picks up the extra blood and brings it back directly into the vena cava system, rather than bypasses the liver. Another area is down here in the area of the rectum. And in that case, the inferior mesenteric vein, which is what is labeled here, inferior mesenteric vein, is going to drain through that area, and it allows drainage back into systemic circulation. So just reminding you again of the existence of the portal system and its relationship with the gastrointestinal tract. Now that we've talked a bit about the thorax and some of the circulatory system in the abdominal area, I'd like to go up into the head, and we'll talk about some specific vessels up there, and we'll go on from there. This first vessel that I want to talk about, of course, is the common carotid as we come up through here. I want to remind you that the common carotid bifurcates into an internal carotid, which is going to go up and supply the brain and orbit region. That bifurcation is at about the level of the superior border of the thyroid cartilage. The external carotid as you can see diagrammed here, is going to course upward, supplying all of the external structures of the head outside of the cranium. And it does it by a series of branches which are probably most easily broken up in the following way. There are basically two branches which are going to pass posteriorly. You have the occipital branch, which is here, and the posterior auricular, which passes in this direction. Then there is a single vessel here, the ascending pharyngeal, which is going to pass off the medial aspect of it. And then we have a series of three vessels which are going to pass anteriorly, the first of which is the superior thyroid artery. Now that just reminds me, and I wanted to mention it to you, the thyroid gland is a unique gland. It's located, of course, down here in the neck, and its arterial supply comes both from the external carotid, and if you remember, the inferior thyroid artery is coming off of the subclavian artery, which would be down in this zone, and then is going to arch up into the gland. So the thyroid gland gets its arterial supply from both the subclavian artery and the external carotid. The next branch that passes anteriorly from the external carotid is the lingual artery, and we'll look at it in a bit of detail in a moment. Then the facial artery will come off and pass forward in this region, and it passes deep to the angle of the mandible and then around the premasseteric notch to come onto the face. It will give off a submental branch, which is going to supply the submandibular triangle and the submental area, and then continue on to the face, where it will divide up and continue as the angular artery and the lateral nasal artery are its two terminal branches. During that course, it will give off branches into the area of the pharynx and the area of the palatine tonsil. As the external carotid continues superiorly, it passes posterior to the mandible in the parotid fossa area and terminates by dividing into two vessels. Now this is a little misleading in this diagram. This one should be considerably smaller than this one. The maxillary artery is going to pass deep to the neck of the condyle and into the area of the infratemporal fossa. The superficial temporal artery will then continue on and pass the base of the zygoma and up into the temporal region. This transverse facial is a branch off of the superficial temporal artery. Now what I'd like to do is to emphasize two arteries that frequently appear on National Board exams. The first one is the lingual artery. It's one of these anteriorly oriented arteries. And it's in an area that's extremely complex. It's the area of the submandibular fossa. We've talked about the hyoglossus muscle taking origin from this greater horn of the hyoid. And I'll mention now the mylohyoid muscle, which we know and we saw in the bony attachment for it to the mandible up in this area, is this sheet of muscle here. You'll notice that there's a cleft between the mylohyoid and the hyoglossus muscle. Passing into that cleft is the 12th cranial nerve and its associated vena commentans. Passing deep to the hyoglossus muscle is the artery we want to consider, the lingual artery, and it will pass deep to that muscle to approach the tongue. Let's take a look and see what happens now. Now, in this case, you've got the tongue, of course, here, the cut mandible here. Here again is our hyoid bone, and over here we can see our external carotid system, and here's our lingual artery. Well, here it comes, and you'll notice this dotted line here, and again here. The hyoglossus has been removed. So the muscle, lies over the artery, and the artery passes deep to it here, and it gives off its branches, its first ones, deep to hyoglossus. And these are simply going to be the dorsal lingual branches as they come off. It then continues under cover of hyoglossus, gives off a sublingual branch, which is going to supply the floor of the mouth, and the rest of it continues up deeply within the tongue and is called the deep lingual artery and will travel to the tip of the tongue in this area. So those are the major branches of the lingual artery, and the relationship here to the hyoglossus is a critical one. The dorsal lingual branches, the sublingual branch, and the deep lingual. Now, the next artery that I want to look at in specific is the maxillary artery. It is one of the terminal branches of the external carotid system. As it comes off, it can be divided up conveniently into three parts, you recall. This first portion, all the branches of which are going to pass through bony foramina. A second portion in here, in which all the branches will go into soft tissue, and a third portion, which is going to go through the pterygomaxillary fissure to pass into the maxilla, and all of its branches will pass through bony holes in order to distribute to the midface. So the maxillary artery, I think the ones that are critical here in the first portion of it, the biggest one that you most likely want to remember is the inferior alveolar artery. It's going to pass downward, of course, and go up foramen spinosum to go in and supply then the middle cranial fossa. Those are the two major branches. Others are related to the ear and less likely to be considered. The middle portion is going to be supplying, as we've mentioned, the muscles of mastication, temporalis, the pterygoids, both the lateral pterygoid, medial pterygoid, and a branch will pass over the mandibular notch to come in here and supply the masseter. Finally, this third portion going through the pterygomaxillary fissure is going to be the one that will break up, and you can see one of its first branches here, the posterior superior alveolar artery, and it will continue the main body of the artery, go through the infraorbital area and appear out here on the face. Branches of it that you would be interested in are mainly going to be the sphenopalatine artery supplying the area of the nose and then coming down into the palate, and the greater palatine artery, which is going to travel downward. You can see it drawn in here and pass into the palate posteriorly. Veins. Well, the major thing in the head that you want to remember is that there are no valves except at the base of the neck. That's an important feature. Unlike other veins in the body, this allows blood flow to go in many, many different directions. It isn't just simply being directed in one direction toward the heart. It's a critical feature because of the fact that infection in the head and neck can pass from one area to another by the veins. Now let's take a look at some of the major ones here. Of course, here we have the internal jugular coming down here. As far as the drainage into the area, you can see the superficial temporal coming down. It joins with a large vein here at the neck of the condyle, the maxillary vein, and forms the retromandibular vein. It lies within the substance of the parotid gland, divides into a posterior division and an anterior division. The anterior division combines with the facial vein, which comes down through here, and the two of them are going to drain into the internal jugular system. A critical point in dentistry is that right in here in the infratemporal fossa is the area of the pterygoid plexus of veins. It's connected by the maxillary vein, by deep facial veins, to a structure then that is superiorly placed and lies in the base of the brain. This is the area of the cavernous sinus. The cavernous sinus lies on either side of the pituitary gland and really surrounds it. And we have a series of cranial nerves that are actually going to pass through or in the walls of the cavernous sinus. Within the walls of the cavernous sinus, for example, you find the third cranial nerve, the fourth, and the first and second portions of the fifth nerve, the ophthalmic division and the maxillary division of the trigeminal system. Within the sinus proper is running the abducens, or sixth cranial nerve, as well as the internal carotid artery as it passes to go to the base of the brain. So you can see that any infection that would get going in the area of the cavernous sinus would endanger all of these structures around which it is lying. And the interconnection from this pterygoid plexus up to the area of the plexus is something, or the cavernous sinus, is something that dentistry is very concerned about. There's also drainage, you'll notice, from the facial vein through ophthalmic veins into the cavernous sinus as well. Now what I'd like to do is to change gears and move into the nervous system. This is an area that we will review a bit specifically in the area of the autonomics, but I'd like to start out first with the concept of the spinal nerve. We'll then talk about the cranial nerves. We'll then move into the specifics of the autonomic supply to the salivary glands as being the example of it, but I want to talk a bit about the autonomics as a whole. But let's start out first with the spinal nerve, and we'll use the overhead for that. Again, this is in your handout. We're talking specifically about this area in here. Here we can see a cross-section of the spinal cord, and you'll notice that it's at the thoracic level of T6. Within the cross-section of the spinal cord, you can identify some things. We refer to this as being the dorsal horn. In this would be the medial horn. And down here, the ventral horn. Now, in terms of the nervous system, we talk about the term central nervous system and the peripheral nervous system. The central nervous system is, of course, made up of brain and this thing we've just labeled, the spinal cord. And the nerves are then going to be the things leaving out from that, spinal nerves or cranial nerves. What I want to talk about first is the formation of the spinal nerve, the components that go into making it.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.